So now it's my delight to actually introduce Prabhjot Singh. Prabhjot is the director of the Arnhold Institute for Global Health and the chair of the Department of Health System Design and Global Health here at the Icahn School of Medicine. On a sort of from my perspective, Prabhjot has in a very short time brought a level of energy, vision, creativity, and a whole new conception around global health that has impacted even a lowly liver doc like me. So it's been a thrill to have him as a colleague, and he in turn will introduce our next speaker. Prabhjot.
Great, thank you very much, Scott. And if Scott's a lowly liver doc, we've got a lot of work to do, all of us. It's with great pleasure and a privilege to introduce colleague, a friend, and an inspiration to me over the last many years, Mr. Suprotik Basu. I'll explain. He's the Chief Executive Officer at the Office of the United Nations Secretary General's Special Envoy for the Health in Agenda 2030 and Malaria. It's a long title, and he has been an able and excellent executive, but I think it'd be better if I gave you a bit of context about his really remarkable mark that he's left on global health and also the impression that's been left on me in my work. Suprotik started his career at the World Bank as a specialist and analyst there and helped bring or deliver about $700 million in loans and grants related to health and development. What is probably most remarkable to me is that there's a small group of people that have really taken a paradigm-shifting view to global health. They start with the end in mind. What does it mean to end malaria, for instance, or end HIV or end TB? And then they work backwards. And they say, is this going to be accomplished in 5 years or 10 years? If so, what do we need to do in order to get there? And they really march it out month by month. They start tracking whether there really is progress toward these goals. They'll look for whether or not investment is truly going to the right areas and the right work is taking place. It's brought a level of professionalism, of rigor, of analysis to the work of ridding the world of disease and improving global health that I think over the last 10 and 15 years has really brought an unprecedented degree of both progress and potential for what lies ahead. And I learned about Suprotik's work in the context of his role in reducing malaria incidence across sub-Saharan Africa. And over the last 10, 15 years, we've realized that it's possible to reduce the incidence of a killer like malaria, which affects largely children across areas like sub-Saharan Africa, and that you just need to take a hard-nosed look at what does it take, if it's bed nets, if it's financing, if it's people, and you just need to start getting people together, build a collaborative platform, make sure that the goals are clear, and motivate people towards them. Suprotik has been at the forefront of doing that for the last 15 years, and especially in the last few years, I've had the privilege of working with him on a range of topics from community health workers to forward-looking work on how do we reduce health inequities across the world. And so it's with, again, great pleasure that I'm inviting Suprotik here and to speak with all of you about what the work has been to date and what lies ahead, especially as he looks forward in his role in leading the United Nations towards a world in 2030 where health is a top-level agenda item and we have made significant strides built upon the gains we've already made. So thank you so much, and please welcome Suprotik to this discussion.
Hi, how are you? Can everyone hear me? I've got one of these fancy mics in my ear so I can actually pace, which is what I prefer to do. Well, thank you so much, Prabhjot, for that very, very generous introduction. It's been a joy to work with Prabhjot and his whole team at the Arnhold Institute over the past, at Arnhold for the past year or so, and then for many, many years before that. This is going to be a slightly, looking at the rest of your agenda, different kind of talk and a different subject than what many of you are probably spend your days and hours steeped in, but hopefully you find it interesting nonetheless. It's going to be about an overview of what goals that we collectively, whether you know it or not, have signed up to achieve by December 31st, 2030. Take a little bit of a look back as to how far we've come, look at the next 15 years, and then think about what are the innovations that are going to be required to actually get to those targets and get to those goals. So let me get the first slide here. Actually, no, not the first slide yet. Let me ask a question first. How many people here, just get a scene set, have heard of the Millennium Development Goals? All right, that's about a little more than half. Great. And how many here have heard about the Sustainable Development Goals? I know these are very catchy titles that the UN comes up with for these names. Okay. All right, great. So why don't you get the next slide, and let me just explain a bit about what the Millennium Development Goals were. They were set, as many of you know, half of you I guess know in this room, in the year 2000. And they're meant to measure progress between 2000 and 2015. There are a set of 8 goals, and I think 18 indicators. And the goals range in terms of what they actually were. So goal 1 was to end extreme or make a major reduction in extreme poverty. Goal 2, achieve universal primary education. Goals 3, 4, and 5 all, is this for me? Oh, great. Goals 3, 4, and 5 all related to health. Goal 3 related to a 2/3 reduction in child mortality in that period. A 3/4 reduction in maternal mortality was goal 5. Combating AIDS, malaria, and other diseases was goal 6. Goal 7 was around universal primary education, and goal 8 was around global partnerships for development. No one to this day knows what goal 8 actually means. But each of the goals very much varied in the way they were monitored, measured, what the indicators actually were. And as you note, probably, not all of them have an equal level of precision in terms of how it's actually measured and monitored. Just to look into goal 4 for a moment as an example, it's a somewhat concrete goal. It's reduced by 2/3 maternal mortality rate between 1990 as baseline and 2015. In 1990, approximately 12 million children did not reach their 5th birthday. Right? That's the overall number in 1990. In order to hit MDG 4, which is this reduction, you've got to get that number down from 12 million down to 4.4 million in that interceding period. The number we ended up getting to as at December 31st, 2015, was a little over 6 million, give or take, depending on when you draw the line. So it's about halving is what happened over that period. One of the most dramatic declines we've seen in public health history, actually. And actually, the slope of the curve was particularly steep in the last 5 years, where the funding substantially increased. And there are some major drivers of this. Measles vaccination was a substantial driver, and Prabhjot mentioned malaria, which I'll talk about a little bit more, was a major driver in terms of what actually took a big swipe at that MDG 4. So I got my own clicker now. So now, if we thought the MDGs were complicated, welcome to the world of the Sustainable Development Goals. The Sustainable Development Goals were agreed on by 150 or 155 countries last September, so September 2015, when the Millennium Development Goals came due. And it is a far, far, far longer list. I've actually written down here because I keep forgetting, but it's 17 goals and 180 indicators. Now, the benefit of the Millennium Development Goals were that they were a relatively small list. They were agreed on by the same number of countries. And to get any set of countries to agree on 8 goals and that many indicators is tough. Imagine how hard it is to get 160 member states of the UN to agree on 17 goals with 180 indicators. The difference in the process was that the SDGs were developed in a bottom-up fashion, as opposed to kind of a top-down New York fashion. So the benefit of that is you have a wide amount of buy-in across the member state community. The downside is when you prioritize everything, you prioritize nothing, and that's the risk of where we are right now with these goals. The goals in general I won't bore you with reading through each of them, but even if you look at some of the health goals here, and instead of 3 of 8 of the last goals, 3 of the 8 goals before were health, now 1 of 17 relate to health, but there are 13 indicators related to that one goal, SDG 3. And if you look at the goals themselves, some of you can read it, some of you probably can't, they also aren't only focused on the poorest countries in the world. They aren't just focused on communicable diseases. They're not just focused on AIDS, TB, and malaria, et cetera. You've got a number of goals in here that reflect the world as we know it in 2015. You have goals around tobacco. You have goals around substance abuse. Mental health for the first time appears in any kind of UN document. Road traffic injuries, et cetera, to reflect the diversity of what the disease burden is across the world. The first several, though, take what we accomplished in the MDGs and then take them a step further into the SDGs. The other principle here that was really important to note is that there's a principle of what's called universality, is that every country in the world has now signed up to achieve these goals. And this is a big controversial point because it's much easier in kind of the UN ecosystem to focus on emerging market developing countries, et cetera. It's much harder to get the United States to agree to sign up to a target, to accept the fundamental inequities from a health perspective, for example, that exist in this country, looking at downtown Newark versus where we are right now. But we did sign up for it in this country, as did every country in the world. Another important point is the MDGs were set as a global average. So take the first goal. The first goal was to, the target was actually to have fewer than a certain number of people living on less than $1 a day. That target was achieved. It is achieved because largely of the growth in India and China. It was not achieved because you had an equitable distribution of in most of the countries in the world. Most people live with more than $1 a day. That's not true in the SDGs. In the new set of goals, in the global goals, many of the goals are defined on a country-by-country basis. So the global averages actually will be misleading. Take, for example, the goal on child mortality, which I've double-clicked into here. The goal is by 2030 to get the overall child mortality rate lower than 25 per 1,000 live births. If you were to take that one average, the bottom graph actually lays that out, you see there are a number of countries, about 48 countries, that are actually on track to achieving that target. If you take the slope of the curve they're on right now, they're on track to hitting that goal by December 31st, 2030. And there are a number of countries that are off track, wildly off track. We'll talk about in a second to actually get there. If you take the global average, you end up at around 22 per 1,000 live births, right? You actually, from an average perspective, probably hit the target. But we're going to miss it by miles in some of the poorest countries in the world if you actually take that average. That's a very big difference from the goals that we have seen before. The average is actually obscure the actual progress we need to make. You then take that a step further, and here you see the 48 countries, the numbers become much more concentrated. So if you take the 48 countries that are off track to achieve the goals, right, that are off track to achieve that 25 per 1,000 live births, about half of that comes down to 4 countries in the world. Nigeria, the Democratic Republic of the Congo, Angola, and Chad make up a little less than half of the residual mortality required to achieve the target. So in terms of, as we think about policies, we think about financing, we think about targeting, what Prabhjot said at the beginning is right. If you actually take the goal seriously and start to problem solve working back from December 31st, 2030, there is no path to victory does not result in those 4 countries having a massive acceleration in progress, no matter what we do in the rest of the world. So there's major, major policy implications. And this just double clicks into that a little bit further. Nigeria and the Congo have to increase their rates of reduction by 2.6, 2.7 times. Angola and Chad must increase their rates of child mortality reduction by 4.5 to 5x if we're actually going to achieve the target. Angola, which is one of the fastest economically growing countries on the continent, despite that, has this burden of child mortality. So even if every other country were to achieve it, we're still going to miss it. We're still going to miss it by miles. So then, what are these children dying of? We made great progress in achieving child mortality reduction, particularly for children above neonatal age. We have really lagged. There's been a big disparity between post-neonates and neonates in the world. So most of the residual mortality in particularly these 4 remaining countries are down to basic neonatal issues: preterm birth, sepsis, birth complications, asphyxia, postpartum hemorrhage for maternal health. All of that has been, as a bucket, by far where we've lagged the most. They are those things that require community health workers. They require more functional health systems. They do not lend themselves to kind of a fire hose approach of distributing a lot of things to a lot of places. They're objectively harder to do. That being said, you still have a significant number of kids that are dying of basic things. You still have far too many children dying of mosquito bite, far too many that aren't receiving routine vaccination. You've got 40% and 30% of kids in Nigeria and Angola are stunted in 2016. So there are some quick wins to still achieve. But the harder part to actually shift has been the neonatal mortality conversation. Now, I was talking a bit about states in terms of countries as the units, but that actually also obscures the way we look at these data, because actually in many countries, the subnational data and the disparities in health equity within a country are starting to become far, far more acute than the disparities across country. And we as a community find it very difficult. It's very difficult from a data perspective, very difficult from a financing perspective, very different from a policy perspective to get that granular. It's much easier talking about things in bigger chunks and bigger buckets. So on the left here, there's a graph around Brazil, which shows I'm sure many of you can't read it, but guessing by the colors, it basically breaks down child mortality by municipality in Brazil. And you see really hotspots of child mortality within the country itself. So taking some sort of a blanket approach in a country like Brazil doesn't make a lot of sense. You can actually waste a lot of time, you can waste a lot of money, without actually moving the needle when it comes to child mortality. Take on the graph on the right, which I think is one of the more interesting ones that I've seen recently, actually, and a student now here at Mount Sinai Medical School, Gus Ruckman, did a lot of these analyses actually for us, working with the data. Take a country like Kenya. Kenya, for example, has both the lowest or amongst the lowest counties with in terms of child mortality risk at 51 per 1,000 live births, as well as one of the highest on the continent of Africa at 149 children not reaching their 5th birthday out of 1,000 live births. So same country. So national policy isn't going to make a huge difference. You really have to get to a much granular, much more subnational level, which is difficult to do. Another example of that: Angola, Chad, Congo, Nigeria, major inequities within the countries themselves. And until we're able to, and in Chad you see that we have no data there, right? Despite all of our best attempts, we were unable to even find the data. And I left that in there for a reason, which is that we simply don't collect these data on a recurrent basis because we're still really speaking about these targets in global and in national averages. One of the things that I'm most excited about that Prabhjot and his team are working on at the Arnhold Institute is something called Atlas, or the Health Equity Atlas, that basically creates a data sandwich, for lack of a better term, right? It both creates a network of community health professionals that go out and actually capture data using handheld devices and combine that with state-of-the-art satellite mapping technology. So you begin to see a granular map of the entire continent, map of the countries, and be able to see how some of these patterns in access and mortality and morbidity change in much closer to real time than we can today. So hopefully things like a gap in Chad will go away. I wanted to end on this slide, actually, and then we can move into some questions and answers in a bit, and not just focus on the developing world. This is Mexico. This analysis was released 2 weeks ago in The Lancet. Every year and a half, they do the Global Burden of Disease study, and it is, in my opinion, by far the most comprehensive trend analysis in the entire world. of who's dying of what where, who's suffering from what where, et cetera, country by country. It has hundreds of collaborative authors, and it was released 2 weeks ago. This is in Mexico, where they did a subnational analysis, where you really see, and I'm sure these slides will be available to you if you're interested, that you've got major differences in life expectancy within the same country, depending on where you actually live, what state you're actually in Mexico. Right? You take Guerrero, which is about 72 as the average life expectancy, and then you're down to 77, you're up to 77 or 78 in Durango. And you see the causes of mortality differ here as well. If you take the orange here, some of you can see, are intentional injuries. Most people here have read about or have seen about or experienced the substantial organized violence that is present in Mexico. Guerrero is the state in Mexico, obviously the lowest life expectancy, but it also has, for the past 3 years, had the single highest incidence of violence in the entire country of Mexico. And you begin to then see how these trends also seem to intersect. You see a substantial number of HIV and TB transmission in the same state. You see, obviously, intentional injuries, et cetera. So it's very difficult, unless you're getting this granular, to actually know what to do. And it's very rare that you actually have this level of granularity to actually begin to address the problem. All this being said, I'm really optimistic actually about our ability to achieve the targets. We are living in an era, despite everything we're reading and seeing, of unprecedented prosperity. We have an amazing renaissance of tools and technological development right now. It's probably the most innovative period we've lived in a very long time. So we do have an increasing number of arrows in our quiver to get at the kind of problems I've described here today. But that being said, unless you take a target seriously and work backward from it as a deadline, not some UN aspirational goal that comes and goes and no one notices, or something where just progress equals success and everyone's just doing good stuff, unless you're actually working back from a deadline. We used to have a clock we hung in our office when we were headed toward the MDGs that counted down from December 31st, 2015, days, hours, minutes, seconds. And unless we take a policy perspective that's in a hurry, because how you achieve a problem, we've learned, how you achieve a problem when you have 7 years to achieve it versus 3 years to achieve it could be very different. And in many cases in the policy, financing, public health world in general, progress equals success. Just because we're doing better, because yes, last year was better than this year, we're winning. And that's not true. That's not true if you're serious about achieving a deadline by a certain time. And it is a different way for institutions to think. What we did collectively in malaria is an interesting example of it. Right? We started in the year 2000 with 1.2 million kids dying from malaria, dying from mosquito bite in 2000 in sub-Saharan Africa. That number is now down to a little over 200,000 children dying per annum in sub-Saharan Africa from malaria. It is one of the single biggest declines in public health history. We are now about to kickstart in the next couple of years a national eradication campaign. Right? Wipe malaria out, as we're trying to do with polio on the planet. Unthinkable 15 years ago. 7.5 million children's lives saved in that same period. Massive. It would not have happened. It would not have happened had we not worked back from December 31st, 2015, for the first few years, have a quarter-by-quarter plan working back from those granular targets, and then manage projected versus actual, quarter by quarter, so that we're able to know how far off we are in any one particular quarter. Now, like any plan, no plan survives first contact, right? It's wrong. It's wrong as of day 2. It doesn't mean you don't have a plan. And so what we're trying to encourage collectively, what I encourage this whole group to think about, is as we think about unpacking and tackling, and whatever anyone's expertise is, a massive global problem like getting to 25 deaths per 1,000 live births down from 40, which is where we are right now, this kind of an approach of unpacking it, working quarter by quarter, working back from a deadline, and paying attention to the subnational granularity of data is critical. And we need more people to think this way if we're actually going to have any kind of chance of achieving the 2030 goals. So I'm going to stop there and see if there's any questions I can talk about.
Great. Thank you so much for that, Prodic. I'll moderate the question and answer session, and I'll take the moderator's prerogative of kicking us off. Prodic, you spoke about both the lack of data, the need to get more precise, and we've heard colleagues, CEO of the Gates Foundation, speak about precision public health as at least one of her areas of focus and passion. Where do you see investments in the research and development side of what you're talking about here versus doing the work on the ground versus planning so you know this sort of stuff and have a progress sense? How do you think about where do we allocate, and do we need more of which of one of the categories?
Yeah, it's a really good question. I mean, take for example malaria. So I've talked about it for a bit. It's currently a $2.2 billion per annum industry at the moment. That's our annual spend, basically, on malaria. Global, domestic, however you cut it. Maybe 2.5 on a good year, right? Any company that was a $2.5 billion company would probably spend 50 million, 60 million, 100 million at least on figuring out where we're going, when, granularity of data, understanding your customer base, understanding that you don't survive as a company unless you actually invest in that level of monitoring. You can't have a company and not know what your P&L statement looks like next quarter. I would say in the malaria field, we'd probably spend collectively barely $40 million total on this kind of monitoring, measurement, data collection, data analysis against a $2.4 billion annual spend. I could be off by $10 or $20 million, but I don't think I'm off by that much. I would say in malaria, we probably spend more because people like Gates and others are very interested. I think we probably spend more on monitoring and that kind of granular data than we do in a number of other areas of public health. And so if you were to use an average, our percentage is far, far lower. And if we could just say, fine, spend 5% of your annual spend on knowing where you're going and knowing if you're reaching the people you say you're reaching, that'd be a pretty good investment. It's one we just happen not to make on a regular basis.
That's great. And I see that we've got a few questions on both sides. I'm going to start with the lady. And introduce yourself, please.
My name is Alex. I'm a researcher here. And I have, if time permits, actually 2 questions which are related to the same topic, which is the Ebola outbreak. So a lot of the countries that you were showing that had like the highest disease burden were countries in West Africa, places like Nigeria, where there's a lot more distrust, I guess, of these international organizations, just given how bad the outbreak was. So do you foresee like this new distrust of these international organizations being a hindrance to establishing these goals? And if so, do you have a solution to it? And another question, kind of since you are a malaria expert, is that I remember reading that because of the outbreak, there was a lot of, I guess, another horrifying outcome of the outbreak was that there was less care put into malaria, given that like a lot of the symptoms were similar. So do you see that also becoming a hindrance to these 2030 goals?
Thank you.
I was planning to write these down so I forget them all. I think one of the single biggest challenges with the Ebola outbreak, and we do not lack for challenges to how that outbreak was dealt, was the lack of appreciation of real community-driven development, right? Of the inherent understanding these communities had of the disease and our lack of respect for that, right? We took a very medical, very kind of public health, very kind of technological approach to a problem that was a social problem as well. And it took a while for the kind of sociologists, anthropologists, kind of social scientists to come in and actually try to unpack what the social norms were. And because of that, we lost time. In the end, that epidemic probably burned itself out. Right? I fundamentally question whether anything we did had a major impact because of how late we collectively got there, because the norms had started to change. So that level of not just mistrust, but the lack of, I think, sensitivity that a lot of external players often have of not trying to understand what is driving an epidemic at a social level, at a community level, is a real blind spot. I think we collectively have, those of us trained in the sciences, I think collectively have don't pay enough attention to that. So I think it's a real risk. You know, a lot of the symptoms were the same, similar, right? High fever, chills, diarrhea. There was a lot of misdiagnosis of malaria for Ebola. And actually, in the end, the malaria mortality rates increased pretty substantially over that period because everyone just stopped seeking care, full stop. All right, because you don't want to go and seek care and then you get stuck in quarantine. And so you had a lot of patients who should have presented with malaria, who should have gotten care, and then the entire health system broke down. That we did see a significant increase in malaria over the period of the Ebola epidemic. So it was a real risk because of the symptoms were quite similar.
Thanks, Alex.
Thank you.
And I'd encourage people to line up behind the mics, please, Scott.
So I enjoyed that very much. In the context of therapeutic discovery, if I understood correctly, your prescription, as it were, is a social, organizational one, not a technological or pharmacological one. Is that overstating it?
Probably.
Where does technology and pharmacology come in?
Yeah, no, it's a good. I focused on the kind of management elements of this in this conversation, but I think your point's the right one. So in just sticking with malaria for the moment, since we're deep diving a bit. In 2000, we had a failing drug in chloroquine where resistance was increasing substantially, right? And you had for vector control DDT, to which there was significant resistance as well, and an insecticide-treated bed net that you had to re-dip every 6 months. Right? Try re-dipping a bed net in the heart of the Congo every 6 months. Right? Not only is it difficult logistically, but the prices become astronomical. Right? But because I think there was a global target set, and because it was clear from a market perspective that a significant amount of money was about to move into the malaria space, shockingly, innovation followed. Right? So the moment you then say this is no longer a $50 million a year industry, which is malaria was in 2000 a $50 million annual international spend. Now we have a $2.1 billion international spend. Yes, Novartis developed an artemisinin combination therapy. Yes, you had net manufacturers develop nets that now last for 5 years. Yes, you have insecticide classes that aren't just DDT. So if we hadn't had that technological innovation, we couldn't have scaled. We couldn't have blanketed the continent with nets, whatever it was. So it had to happen in sequence, but I would argue that without setting that goal and without having the target and the funding mobilized to achieve it, you know, we can limp along technologically, and one day you'll get a drug for a poorer person that'll do some good, or you can create a market for it, and then shockingly breakthroughs happen on a faster clip. So,
Great.
thank you.
Thanks, Scott. Please.
Hello, my name is Gabriel. I'm with Energy and Health Mentors International, and we work with various UN member countries on implementing their SDG plans. One thing that I would like you to comment on is how important is it to the UN and overall as a plan for the success of the plan to address the interlinkage or the integration or the interconnection of the various SDGs. For example, in my particular case, it would be directly the transition from fossil fuels to renewable energies and the impact that has not only on the environment and climate change, but more importantly on health, especially in places where you have a lot of coal use, but also in places where you have, like in Africa, a lot of high sulfur diesel use, like Nigeria and other places. Thank you.
Well, it's really important, actually. And it's very, you know, we have within the health sector alone tough breaking out of our individual subspecialties and expertise. It's even harder to do that when you then look across different sectors. And I would say the rhetoric-reality divide when it comes to intersector collaboration has been fairly large. But these problems are becoming increasingly interconnected. So it requires you to look at it from to some extent, to look at it from a perspective that is not focused on your one individual target you're trying to achieve. I think the SDGs, as much as people criticize them for being, you know, too broad, too vast, I heard once someone say it was no target left behind was the way people describe the SDGs, which might be true. The benefit of it is it does take a much more holistic approach. Now, organizationally speaking, not just the UN, but organizationally speaking, we're not built to do that, right? We are trained as experts in various things, or organizations are built to be experts in various things, and the bureaucratic and the performance incentives are generally aligned toward the thing that you were trained to do or that the organization is getting funded to do. So again, it requires a change, I think, on the incentive side to truly get different groups to collaborate in a much more seamless fashion.
Great, thank you.
Sure.
Hi, my name is Jacob. I'm a grad student here. A couple weeks ago, or 10 days ago, Doctors Without Borders declined like 1 million vaccines from Pfizer for free. And in that context, I was curious about the efforts of the United Nations in terms of partnering with a lot of these bigger companies that have a lot of the resources and money that can help, and where you see, for example, the Doctors Without Borders making this stance, which is a really big example of like one market across the world affecting a market in need, you know, in a country that is really poor, and any kind of partnership or any initiatives that the UN has taken in that regard.
Sure, Jacob. You know, like it or not, industry has a pretty substantial role to play in terms of providing us with the technological pipeline we need, past, present, and future. And particularly when it comes to diseases of the poor, where the market is not necessarily as evident, the general approach is how do you then put your finger on the scales a little bit to create a market where one doesn't naturally exist. So for vaccines as one example, there's something called the Advanced Market Commitment that was done related to the World Vaccine Fund, the global, which is called Gavi, the Global Alliance for Vaccines and Immunizations. And in that case, they had trouble in the early days of getting manufacturers to step up production of vaccines because they weren't just going to donate the vaccines, and they weren't going to try to do research in the new vaccines because there was no market to actually purchase the vaccines. And so a number of countries got together and said, fine, we will guarantee a certain minimum offtake agreement if you produce these things so that you can at least do it at a no profit, no loss basis, right? We've done similar things with malaria drugs, for example. So yeah, I mentioned Novartis and artemisinin and combination therapies under the trade name Coartem. They sell that at a no profit, no loss. There's no objective reason they need to keep making Coartem. It's not a very good, lucrative drug for them. But because there's a certain offtake guarantee that's offered to them on an annual basis, same thing with BedNet, same thing with a number of other products, it does allow the manufacturers to stay interested in the space. Now, that's not to say that it's a whole different conversation around should the manufacturers do this regardless of the profit incentive or not is a different conversation, and one can have a pretty vigorous debate around that. But looking at the kind of the P&L world in which we live, the way in which the UN and other entities have tried to deal with those incentive problems is to show that, yes, at least there'll be a minimum offtake for you to guarantee these things. Similarly, for new drug development, JP Morgan and the Gates Foundation put together what's called the Global Health Innovations Fund. And what they do is basically once you've gotten through basically the valley of death, I think, for most of these drugs, there's a guarantee that's put into place. A group of private investors in the Gates Foundation that basically say, look, if you get past stage X, Y, or Z, right, we will fund the remaining stage of your research, or at least co-finance it with you. So different ways you can start cutting away at the risk that a pharmaceutical company or a vaccine manufacturer would have to proceed, where from a strict credit committee standpoint, it would never pass. So
Cool. Thank you.
sure.
Great, thank you. Thanks for that, and I'd love to just